Let's begin with today's meeting with our memorial Dr. Faganel lecture. This is the 36th lecture in a row. This year's lecturer is Professor Stephen Laureys. He's a leading clinician and researcher in the field of neurology of consciousness. He leads the coma science group at the University of Liège in Belgium. He's clinical professor of neurology at the Liège University Hospital and research director at the National Fund for Scientific Research. He's a member of EAN Scientific Panel Coma and Chronic Disorders of Consciousness, which published new guidelines on the diagnosis of coma and other disorders of consciousness. And he will talk about this in his lecture. Professor Laureys.
Thank you very much, lads. It's an honor to give this lecture, the 36th, if I understood. Thank you, everyone, for being with us, discussing a very challenging topic, which is coma and disorders of consciousness. I hope to be with you in wonderful Ljubljana. Congratulations for putting this up. Feel free to contact myself or someone from the team here in Liège or now also in Canada, and that can through the different channels you see here. We can go to the next slide, which covers the topic of what I would like to discuss with all of you today, and that is about the big mystery of studying human consciousness. I think it is one of the biggest challenges for us scientists, comparable to these other tremendously difficult questions about the origin of life or the origin of matter. There is a clear added value of functional neuroimaging, and with the different themes here, we look at perturbations of consciousness when the brain is damaged. That we'll be talking about today, coma and related state, but also pharmacological coma or general anesthesia. And finally, the changes that occur in our level and content of consciousness during hypnosis, but also meditation. And then we have all these tools that you can see here, ranging from electrophysiology, and you're all experts in that field, or glucose positron emission tomography, or MRI, both structural and functional. Next slide. So it's not easy, and I will spend some time defining what we actually mean by consciousness. And next we will discuss the current state of affairs regarding our scientific understanding and the so-called neural correlates of consciousness, and then translating that knowledge into a better clinical care. And there we basically have three challenges. That's reducing the diagnostic uncertainty after coma, also the prognostic uncertainty, and finally improving our therapeutic options. And we will conclude with some ethical considerations. So consciousness is something that we actually fail to define. There is no definition we all agree upon. And yet, as clinicians, for those of you who are seeing patients, we of course are supposed to know what we mean when we say someone is conscious and, for that matter, unconscious. So we will reduce the complexity of consciousness into two main dimensions, and that's what we do in neurology. That is, first of all, assessing the level of consciousness, and that is wakefulness. And next, the content of consciousness, and that is our subjective awareness of our environment, which is actually what we will be losing when we fall asleep. Maybe some of you during this lecture, I hope not. But also during dreaming, we see that there is a notorious exception where one seems to be asleep, unconscious, and yet you can have these very vivid oniric dreaming activities or even lucid dreaming. So it illustrates very well how challenging it can be for us as clinicians, but also scientists from the outside to say meaningful things about this first-person experience that conscious awareness is. Now, coma is a patient who by definition cannot be awakened. So patients who are comatose after traumatic brain injury or anoxia or whatever the cause will never open the eyes even when we stimulate them. And that is exactly how we at the bedside clinically assess the level of consciousness or wakefulness. And the same holds for general anesthesia. Now, since the 70s, it was clear that some patients survive coma, open their eyes, and yet fail to show anything more than reflex movements or automatic behavior. This term was coined persistent vegetative state. It is a term I do not like, and I will throughout the lecture, and I very much insist on you considering do the same, avoid vegetative state. Because it is pejorative, we will not compare human beings with vegetables. And we within the European Academy of Neurology and our colleagues of the task force have proposed a new name, now also accepted by our colleagues in the American Academy of Neurology. So we no longer use vegetative state, but use unresponsive wakefulness, which is basically what we see. Patients awaken after their coma, open their eyes, but they're not responsive to any of our verbal prompts. There's other examples in neurology. You all know epilepsy, absence seizures, or complex partial seizures, but also sleepwalking. Patients show automatic motor behavior, but fail to pass the awareness test, which is us looking for a response to a simple command. Now, this can be very tricky, and we've repeatedly shown that it can be tricky, and that many of the patients we think are unresponsive in reality are minimally conscious, or maybe we should say minimally responsive. This entity was defined in 2002, and we have proposed a subdivision into MCS minus patients who after coma evolve to unresponsive wakefulness, meaning they open the eyes, on reflex movements observed, and then they will start to show more, meaning they could orient to pain, or they will show visual pursuits, or they will react to specific emotional stimuli, very often in response to the family's presence. We can't say it's a reflex, but it's all we got. MCS plus, the plus stands for response to command. So there a patient will, in a reproducible way, answer a question like squeeze my hand, close your eyes, and yet we can't functionally communicate through any motor code. So this is different from the locked-in syndrome. You all know patients after coma and a brainstem lesion evolving to a fully conscious, yet fully paralyzed clinical entity, where for anatomical reasons, as you know, it's only the voluntary control of the eyelids and eye movements that permit them to say, yes, I am still in there, and you can communicate through eye movements on specific yes, no questions. So we're reducing consciousness to two dimensions, the level wakefulness and the content awareness. Next, I would propose to again reduce awareness into two main components. And that is external awareness, which is anything coming through your senses, what you see and hear right now, perceptual awareness. And it seems to be the case that that has a specific neuroanatomical substrate. In frontoparietal associative areas, you see them colored in red. And this is one of my take-home messages, that we can identify not one, but two consciousness, or I should say awareness networks. The one we see in red is the external awareness network. Next is internal awareness, this little voice talking to yourself right now, permitting you to do mental imagery, anticipate the future, autobiographic memory. The little voice talking to your head depends on, in blue, mesiofrontal, anterior cingulate, posterior cingulate, and precuneus, part of the default mode network. This internal awareness network and its interactions, illustrated by the black arrows, also through non-specific thalamic nuclei, seem to be critical elements in awareness of the environment and of self. Next, we will, of course, use this, next slide, to better understand our human mind. Some would use the word spirit, soul, and there we touch upon a very, very challenging area where historically religion and science have sometimes had opposing views. And I'm not a priest, I'm not here to say anything about what may or not may happen after death, but we do study near-death experiences, and I would hereby like to invite you to join us in that effort. We now have nearly 2,000 of patients who tell us what they were actually feeling when we thought they were comatose. These so-called near-death experiences, we've published quite extensively on the matter, and I really would like to increase our efforts to better understand this phenomenon that some take as proof of life after death. I would be more careful. I think the only scientific proof of life after death we currently have is organ donation, and I also would like to talk about that. So you see the email NDE from near death experience at uliege.be. Please contact us, and I would be very happy to collaborate on this or any other matter. And also, if you have patients who had these experiences, please have them share this with scientists like ourselves so we can make progress in a very, very complicated field, which is the borders of life and death and our subjective experience. Next, coming back to neuroscience and the importance to study consciousness with neuroimaging technologies. When I started this in the 90s, I think the field of the study of coma was kind of comatose itself. It was with my colleagues, Nicholas Schiff in New York and Adrian Owen in Cambridge, that we were truly the three musketeers doing pioneering research using these machines to go and look what's happening in the brain when you had these disorders of consciousness. Your brain right now uses more energy than any other of your organs for its weight. And if I inject radioactive sugar, I can see that. This is what we see next when we look at normal consciousness. Your billions of neurons use a lot of radioactively labeled glucose. We can visualize, you see a lot of yellow, red, a full 100%. Now, brain death, the irreversible destruction of that, gives a very different image. You only see the skin around the skull still using some energy. When your brain is dead, you are dead. Now, in deep sleep tonight, you will have a massive global reduction of about 60% of normal values. However, when you are in REM sleep and dreaming, your overall brain activity is very close to normal. When we give anesthetic drugs, we see again a massive drop, less than half of normal values. And when we stop the drug, patients recover consciousness and they recover a full 100% of their brain activity. Yet, consciousness, as some initially thought, does not depend on the activity of just the whole brain. We've shown, when we look at patients who are in unresponsive wakefulness, previously called a vegetative state, that yes, there is a massive reduction. But when they recover, they don't recover a full 100%. They recover activity, functioning connectivity, in part of the brain, especially the awareness network, which is kind of a global workspace, frontal, temporoparietal, both hemispheres, external, and then midline, internal. And that we can see on the next slide is what we could show with the team. So just looking at global activity shows overlap. It's not giving us the total picture. And the next slide shows that there is a critical network. You see it here in orange, that is systematically dysfunctional. And that is for any cause, traumatic, anoxic, toxic, hemorrhagic. When you damage both of these awareness networks, external and internal, of both hemispheres, you will be alive, you will be able to move, but you will not have a functioning mind. External or internal awareness will be impaired. As it is in complex partial seizures, the studies here using SPECT have shown. As it is in absence seizures, you see this network is blue, it's going down. Here an Fmri study using bold measurements, or Claudio Bassetti, who was, I understood, a previous speaker at your conference, again showing during sleepwalking with SPECT imaging a reduction of these networks when there is automatic behavior but no response to command. Next, we could show that what really matters for you to hear me right now is your awareness network. You hear not just with your ears or auditory areas. As we showed in patients in unresponsive wakefulness, they also activate this primary sensory area. And in the minimally conscious state, we see that the activation is different because the connectivity of these primary sensory areas, which I would call slave systems, is different when you are consciously perceiving sounds and words and understanding them. So patients who are comatose or unresponsive can still activate part of the brain up to brainstem, thalamus, and primary areas, but it fails to connect to this frontoparietal network, as we could show, and you see that in blue already many, many years ago. The same hold next if we look at high density EEG, that permits us not just to look at functional connectivity per se, but also the directionality. This is a collaboration with the team of Chris Frith in London using dynamic causal modeling. So we again use auditory evoked potentials, how the brain reacts to sound, and then look at one, the response in primary auditory areas, or two, secondary auditory areas, and then three, this part in the prefrontal cortex of the external awareness network. And it seems to be the case that for you to consciously hear, you need this top-down feedback connection, the arrow you see in red, from the higher order frontoparietal areas to these lower level sensory areas or slave systems, right? So consciousness seems to be depending on these feedback top-down connections that you can see here in a paper now published 9 years ago. Next, we will try to better understand, again using EEG, and that's your area of expertise, how these patients fluctuate. It's very, very frustrating. Those of you who see these patients will know that sometimes you examine them and there's nothing at all in terms of their motor response to any of your prompts. And then you would come back a couple of hours later or the next day and you will see something. So this fluctuation is very frustrating and needs a better characterization. So we've been doing long duration EEG, looking at here simple entropy measures, and what you see is that patients who are minimally conscious seem to have these windows of opportunity, meaning their EEG entropy, probably correlating with capacity for awareness, would go up and down, and with a periodicity of about every 70 minutes. If this is true, this could help us in our clinical assessment, but also in the treatment possibilities. Maybe we should give our treatments at specific moments in time. So this is, I think, a very interesting area of research, looking at these ultradium rhythmicities, EEG-wise, that we don't fully understand in health and disease. Next, we can use EEG coupled to TMS, transcranial magnetic stimulation, you very much know, but here is combined with simultaneous, and this is challenging, EEG recordings, permitting us to test the theory proposed by Giulio Tononi that says basically that for you to be conscious, the information needs to be integrated. And together with our colleagues in Milano, we've been developing what was called Perturbational Complexity Index. So we will perturb the brain with a strong TMS pulse and simultaneously look at this electrical echo, and the complexity of that perturbation will give us something of an information regarding the capacity of this brain to have conscious thoughts and feelings. And we propose something very ambiguous, to collapse conscious awareness to one dimension, from 0 to 1. And if you're below 0.33, you are unconscious, anesthetized, in deep sleep, or in an unresponsive wakefulness. And if you are above, you are minimally conscious or locked in, or that is what we've seen in the many, many healthy volunteers we have studied so far. Next, we will again try in healthy volunteers to link subjective phenomenology, the neurophenomenology of what I am perceiving right now is something that merits more attention, because we can't make any use of the most sophisticated neuroimaging or EEG data if we don't know what this person was perceiving. So this is what we did here, healthy volunteers in an Fmri scanner, and they were asked to do just nothing. So what do? You think. You think about what you're hearing around you, external awareness, or the little voice saying, I need to do that, and you think about your girlfriend, mother, whatever, internal awareness. And when we gave these volunteers a little beep and asked them, tell us what you were perceiving or thinking just before the beep, we used these scores as a variable of interest to see how the Fmri time series was correlating with these measures. We see that at the behavioral level, we have one or the other. So at any given time, I'm more aware of what's happening around me, or I'm more aware of the little voice in my head, mental imagery. And in terms of the brain activity, we see the external awareness network we identified in red and the internal awareness network in blue that again show this anti-correlation. We have a number of papers showing that this is important because the activity in these networks actually influences how I will perceive my outside world, and also regarding my self-awareness. Next. We challenge this by looking at general anesthesia, many papers, many drugs. You can see it on the slide: propofol, ketamine, dexmedetomidine, midine, xenon. And again, and what you see on the slide, when you are knocked unconscious because of any of these anesthetic drugs, you see a breakdown of functional connectivity here as measured with fMRI when you go from wakefulness to mild sedation to unresponsiveness to recovery, as you can see on the graph. And here the internal awareness or default mode network breaking down when patients are in a pharmacological coma. But it is not so for their sensory areas. You see in anesthesia, there's still activity in the visual areas, in the auditory areas. So these are necessary, but we believe not sufficient to give rise to conscious thoughts and perceptions. Next, we use hypnosis. We have a very strong tradition here for the medical use of hypnosis. More than 10,000 patients having general surgery, and they are not anesthetized, they're in a hypnotic state. We did the same in healthy volunteers in our different brain scanners, and we could show again a breakdown of functional connectivity during hypnosis, different from distraction, different from normal consciousness. So this state of absorption, dissociation with less external awareness seems to be again linked to a breakdown of connectivity in the external awareness network. Next. We try to translate all of this into our clinical care. So this is fascinating. I'm not just a brain scientist, I'm also a clinical neurologist, taking care of patients. we published repeatedly that we should be very careful. For those of you seeing patients, do not go into a room, do your classical neurological exam and come out and say he or she is vegetative, because you will be wrong in about 1/3 of the patients. This has been repeatedly shown. You need to do standardized and validated behavioral assessments, such as offered by the coma recovery scale that we use, but now next also with a new scale that is the seconds, that is very quicker and simpler. And again, I can provide information if you want to work on some validation on this new scale that we developed for your patients in your centra. So to sum up, when we have a severe brain damage where the patient is comatose, things can go very quickly, very wrong. That's brain death. Or the patient can survive, and when next there is reflex movements, but only eye opening, it is coined unresponsive wakefulness. Do not use anymore the term vegetative state. Next is recovery of appropriate smiling, crying, localization to painful stimuli, or visual pursuit, where you should use a mirror. We have repeatedly shown that a mirror grabs attention of patients. So this is not very expensive. So everybody seeing patients, trying to make the diagnosis after coma, whether they're unresponsive, minimally conscious, when you look at eye tracking, do it with a mirror. Next is the recovery of command following. So this is going from MCS minus to MCS plus. Now what you see on the left is the difference we observed in brain activity as measured with glucose PET imaging. And this is the most direct synaptic marker we have. And you see that in MCS minus, patients who fail to answer to simple verbal commands, there is damage left lateralized in the dominant hemisphere encompassing the language network. So very, very important for everybody, including clinicians, to know is our potential bias. When we look for command following, we request and we take for granted that the patient will understand language. And that is not always the case. It is not the case that the patient is aphasic, that he is unconscious. He can still appreciate music, chocolate, Belgian chocolate, or music. So very, very important to be aware of our own limitations when we assess wakefulness and awareness at the bedside. Next, of course, is the important milestone of the recovery of functional communication. So this is the emergence of minimally conscious state, gives the patient again his right for auto-determination and autonomy. Okay, so on the next slide, you see how we use artificial intelligence, machine learning by all possible means to help us do better than our human eye can in the interpretation of these brain scans. So we are part of the Human Brain Project. We have very, very good engineers, physicists, and statisticians, and many collaborations making sense of these bigger and bigger databases and translating that to the diagnosis, but as you will see, also the prognosis. And you see here the sensitivity, specificity, and the added value of here PET imaging using radioactively labeled glucose in unresponsive wakefulness in minimally conscious state, and the difference in their functional neuroanatomy with a partial recovery of the external awareness network in the case of minimally conscious state patients. On the next slide, we see we can do the same with resting state fMRI. Again, a bunch of papers using so-called resting states fMRI BOLD series and using algorithms to decode, classify multicentric studies showing the added value of the functional integrity of the different networks, default mode or internal awareness, frontoparietal salience, important for emotions, auditory, sensory, motor, visual, and so on and so forth. Next, we looked at not just disconnections. I think unresponsive wakefulness is a disconnection syndrome, but as Carol Di Perry, a bright neuroradiologist from Italy who did her PhD here, showed, we can and should also look at hyperconnectivity. She repeatedly showed that some parts of the brain are having abnormal hyperconnectivity. And that might actually be bad for the brain. And if it is true, and she showed actually that those parts of the brain that have increased pathological hyperconnectivity have lower metabolic activity. So then our treatment strategies are not just to stimulate parts of these networks, but maybe to inhibit others. And that is exactly what we're trying to find out and to do right now. Next, we used Fmri to actually communicate with some of these patients. So we were the first center to be able to communicate with a patient who was sent to my center here in Belgium with the diagnosis vegetative state. And we proved that the diagnosis, the label was wrong. When we asked him to imagine playing tennis, he activated his premotor areas. You can see it on the slide. A very damaged brain, a lot of secondary hydrocephalus because of the tremendous cortical damage. When we asked him to walk around in his house, this young post-traumatic brain damaged patient, he again activated different parts of the brain. So then we said, well, we know you understand, and we now ask you questions. And when you want to say yes, you activate, you imagine playing tennis, do the motor task. When you want to say no, you do these spatial navigation tasks. Very, very complicated. And yet you see that the computer could decode the fMRI signal. Question 1, red, motor, he says yes. Question 2, blue, he says no. 3, no, then yes, then no, and then he didn't say anything anymore. So this is a proof of concept. Next, of course, is to offer these patients more cheap and easier to use brain-computer interfaces based on EEG. You know this very well, and a lot of papers and advances have been made, including this one, where we again use EEG-based computer interfaces and ask patients to move their foot, move their hand. We know Penfield homunculus, so the computer can decode this and give some rare but existing patients a voice, a way to communicate. Next. We put all of these studies together and have shown that they have prognostic value. As we said, 1/3 of the patient, our bedside diagnosis is wrong because we don't use the proper behavioral scales. Even if we do, again, 1/3 of the patients will show something that is completely inaccessible, even by the best and repeated behavioral measure, because we showed we should do at least 5 clinical assessments. So very interesting, big data set at the time, over 130 patients. We now have many more, and the added value of neuroimaging in terms of the prognosis, those with atypical patterns afterwards showed better chance of recovery. Next, we try to better characterize this neural plasticity. Why do they recover? Again, here using EEG and sleep-wake recordings showing that MCS patients actually not only have spindles and partial thalamocortical connectivity, but also the characteristics of what we believe is REM sleep. They could be dreaming. We never will know for sure because, of course, they can't communicate. So again, looking at the slow wave activity propagation, we're testing hypotheses about synaptic homeostasis and trying to translate better scientific knowledge to better clinical care, which is next. What permits also next with MRI to characterize the structural necessity for functional connectivity, a structural connectivity, is the integrity of the white matter. And diffuse MRI, which we use routinely, is permitting exactly that. So we have, with our colleagues in Paris, repeatedly shown that diffusion MRI in both anoxic, traumatic, acute, and chronic patients have added prognostic value. So very, very fascinating. Next, to see how, again, better understanding the process of recovery leads to better treatments. A very old paper now came out in the Lancet 20 years ago. And by the way, today is a very special day, because if you go to the website of the Lancet, or if you read this week's issue, you will see there is a special profile about our team. And I'm very, very proud that the most prestigious journal is paying attention to the fascinating field of the scientific study of consciousness and the clinical translation into the field of coma and related states. So please read this week's Lancet profile. It's a 20-year anniversary of this paper, where we showed that patients who were unresponsive wakefulness, at the time we called them vegetative, had these disconnections between your part of your frontoparietal network and non-specific intralaminar thalamic nuclei. We could show this. And then Nicholas Schiff actually put electrodes right there and could publish in Nature a couple of years later that the first patient with post-traumatic encephalopathy was improved in terms of his level of consciousness thanks to this bilateral deep brain stimulation. Many, many things are now possible. There's a recent review in the Lancet Neurology where we actually review this together with our colleagues Nicholas Schiff and Joe Giazzino from Harvard. And you see on the next slide, we have different drugs. We have electrical, non-invasive stimulation, such as TDCS, transcranial direct current stimulation. I think we've done pioneering work, and that's done by Aurore Thibault from our team. Next, to permit to next go from better science to better care. So this is exactly what the team is doing, putting 2 electrodes on the head, 20 minutes a day, 2 milliamperes, showing half of these patients show some improvement. Also now using vagal nerve stimulation. And on the next slide, you will see that Olivia Gossery's team is pioneering the new pharmacological clinical trials, in this case with apomorphine. First results are positive, but we need, again, more patients, and we will better characterize the inclusion criteria of who and in which condition we can prescribe this to our patients. So next, and in conclusion, I would like to emphasize the ethical importance of all this. One could ask the question, well, why do all this? I don't care if my patient is unresponsive, minimally conscious. It's kind of useless. As long as the patient can't communicate, it's not worth doing. It's maybe not a life worth living. And I think that is wrong. I would challenge that. I think it's tremendously important to increase our efforts. We can't do good medicine if already our diagnosis is wrong. And we've shown that it's tricky. We've shown also here that it does matter tremendously. As soon as you've shown that the patient is minimally conscious and not completely unconscious or unresponsive, this person can perceive emotions. We have shown that they can perceive pain. You see here that the whole pain matrix activated, as we could measure by functional neuroimaging. So they can say, I'm in pain by definition, but I think their brain scans do, and we should systematically address the issue of giving painkillers to patients in these disorders of consciousness. Next slide tells us something important. That is that we shouldn't judge a book on its cover. Locked-in patients are completely paralyzed. They need care for all activities of daily living, and they can tell us what it is like to be in that condition. And we can see that on a scale from -5 to +5, the majority of them actually tells us that they're happy. Some -5 are not and actually ask for euthanasia. But so very important. And I want to know what it is like to be minimally conscious, if this is a life worth living, or if we should stop our life-sustaining treatments. The only way to make progress in this field is to have more science and to let the patients and their families take part in this discussion. The next slide comes into the conclusion of how I hope I've shared with you some scientific evidence from our and other teams that conscious awareness is an emergent property of the collective thalamo-frontoparietal global workspace and its network dynamics. With external awareness and frontoparietal external awareness networks in red and internal awareness in blue, overlapping with the default mode. And if that is true and we can capture the impairment in the structural and functional activity of these networks, we can translate it into a diagnostic use, reducing the uncertainty there. And the same for the prognosis. And we've shown repeatedly the added value of all of these tests. And then finally offer for these very vulnerable, but I believe neglected patients, new therapeutic options. For too long, we said there's nothing we can do for any of these patients. So together with our colleagues, Nicholas Schiff in Cornell, very happy to change that. Yes, we can do something, and we should. And new technologies are challenging our clinical boundaries between unresponsive wakefulness, minimally conscious, and then communication. We see that there are EEG, event-related potentials, and that's your domain of expertise, revealing subclinical command following. And for some, EEG brain-computer interfaces enabling communication that is not dependent on motor pathways. So next, I think we can again translate that to all of these therapeutic possibilities, going from deep brain stimulation, TDCS, to drugs such as amantadine. Zolpidem, a sleeping drug, gives sometimes very spectacular results. We've seen 6 patients, apomorphine, and that, I think, is what we do all of this for, to offer these patients a better quality of life. So next, and in conclusion, I thank the team for doing this wonderful work. For those who are interested, I've been talking about consciousness, but I've also been talking about the power of the mind, taking care of others, but also taking care of yourself. And there's a book in English that comes out next year, which is about meditation. And I do believe it is very important and not to be neglected that we who are at risk for burnout also learn to listen to our mental states. And I'm launching a number of projects in the field, not just of meditation, also hypnosis, as I told you before. So next is the creation of a foundation, and I would all invite you to join. This is the Mindcare International Foundation, where our motto is taking care of the mind in health and disease. Please contact us. It's new. It's being put together now, trying to offer a platform for all of these families, and they're in need of information, of involvement, of support, but also of all of us, as said, trying to take care of the mind. I thank you for your attention, and I hope we have a little bit of time for some questions. Thank you so much.